Thank you, and welcome to the afternoon home stretch to everyone, and thank you for that introduction. So I'm going to be talking about surgical prophylaxis and presenting the results of the 2016 surgical NAPS. And the reason why we're focusing on this is when you look at hospitalisations in Australia, around 10 million hospitalisations occur each year, and 1 in 5 of these hospitalisations involve surgery. So it's not unsurprising that on any given day, the major indication for antimicrobial usage in hospitals is actually for surgical prophylaxis. Unfortunately, surgical prophylaxis also has the dubious honour of being the leading reason for inappropriate use within the hospital system, with around about 40% of antimicrobial use in hospital for surgical prophylaxis being considered inappropriate. The NAPS is brilliant for benchmarking across hospitals, etc., but there are some noted limitations particularly when you're looking at prophylaxis. It's a point prevalence, so it doesn't capture the entire surgical episode, and it doesn't capture day cases, which is a significant number of surgical cases. It also doesn't capture cases where prophylaxis is not required, and it's not linked to patient outcomes. The other challenge when you think about measuring appropriateness is it's not just one thing. There are a number of things for appropriate surgical prophylaxis. You have to have the right patient and the right surgery, the right drug, the right route, the right dose, and the right time, including redosing, and then the right duration post-op. With these things in mind, again, part of the work through NCAS is that we went on to develop the surgical NAPS, which is a period prevalence survey. We're collecting data on risk factors, the surgery itself, peri-procedural procedures period, but also the 30-day outcomes. And this was developed with feedback from key stakeholders, and these were the things that were considered quite important for them, particularly the 30-day outcome data for surgeons and anaesthetists to know that sort of data is relevant for them and their practice. Again, as part of the process, we looked at how do you measure appropriateness and came up with some clear ways to define appropriate practice in this setting. So the SNAPS was piloted in 2016 and it was piloted across 67 hospitals with broad representation across Australia. We also had impressively broad representation from private as well as public, which is great. From the data, we had over 4,000 procedures recorded, of which the majority were elective surgery. And looking at this complex graph, but essentially when we looked at those 4,057 episodes, antimicrobials were prescribed in about 2/3 of procedures at the time of the surgery, and then about 1/3 of procedures had antimicrobials prescribed post-operatively. Probably when you're thinking about your day-to-day practice in the hospital and when you're thinking about the types of surgery and the types of patients you're seeing, not unsurprisingly, a lot of the prophylaxis was for orthopaedic surgery and abdominal surgery, but we had quite a broad representation of all sorts of surgical procedures, including perhaps procedures that we don't always think about, such as dental surgery. So this was quite good representation. Now looking at the results, so we broke the results down into the antibiotics that they got at the time of surgical incision, or that peri-procedural time, but also looked at post-operative or post-procedural antibiotics. And when we looked at appropriateness, we were able to break it down according to the surgical procedures, and this is where we get some really interesting results. So if we look at our vascular surgeons, unfortunately at the time of surgery, nearly or over 60% of patients, their antimicrobials were inappropriate at the time of surgery and vascular surgery. Comparing that with, say, gynecological surgery, where about 25% of antimicrobials were considered inappropriate, with the vast majority being appropriate. So certainly this gives us an idea about where we potentially need to focus some of our research and education strategies. Also, another thing that we noted was documentation around the time of surgery, particularly documentation of when the antimicrobial was given. This is a pretty standard thing that should be recorded, but really it was the exact unable to know when the antimicrobials were given. And often anyone who's done the audit, you often see these sorts of things where the antibiotics are just written across the chart, or a personal favourite of mine, which was sent to me, I think Elsewhere was the Kefa-Met as an antimicrobial. Looking at the antibiotics that were given, not unsurprisingly, cefazolin was the most common antimicrobial that was given at the time of surgery, which is in keeping with what's in the therapeutic guideline. However, we did see quite a lot of creativity in other antimicrobials that are given. So quite a lot of antimicrobials where there's no sort of guidelines to indicate or to support the use, we were seeing their use. Looking at measures of appropriate, so in those antimicrobials at the time of surgery, around 40 or 38 or 40% were inappropriate at the time or non-compliant with guidelines at the time of surgical incision. So consistent with what we've seen and certainly an area of concern and an area for improvement. Again, when we look at the reason for the inappropriate use, the main reason was actually incorrect timing and the second one was incorrect dose. So again, giving us an idea of where to focus. Turning now to post-procedural antibiotics, these are antibiotics given following the surgery. We're seeing a different picture in terms of which surgical specialties are leading the inappropriate use, and in this field, the cardiac surgery were the most common reason for inappropriate users of antimicrobials in the post-procedural period. Again, when we look at post-procedural antibiotics, cefazolin again is the leading antibiotic, but you'll see the second runner-up is cefalexin. Again, this is not in any guidelines at all, and it's often given just as when patients go home, they get a discharge script of cefalexin. And this is something that we've all sort of noticed, but it's really interesting to see it actually borne out into the actual audit itself. This is probably the most telling chart of the whole discussion. So this is looking at our post-procedural antibiotics. And when we have a look at this, over half, nearly 60% of the antimicrobials in the post-prescription period were considered inappropriate. And the main reason was incorrect duration, so patients giving antibiotics when they don't need it, or they were given antibiotics for a too long a period. And looking at the different procedures, just highlighting a few. So these are the ones where we've seen some very creative antimicrobial use. So plastics and reconstructive surgery, the median duration was 6 days of antimicrobials. And 70% of patients had greater than 48 hours of antimicrobials given. Similarly, when you look at head and neck, and also, dental procedures, 93% of patients had antimicrobials given for greater than 48 hours, and these are procedures that don't need any post-op prophylaxis. So again, it's giving us an idea about where we need to focus our education and which groups we really need to think about and target. These results are, we know that it's a common thing that we see that antimicrobials are given inappropriately in this period, and it's something that we've been consistently identifying. But the next step is really, how do we change this behaviour, which has been a common theme, I think, today, and probably a lot of the themes that we talk about now will be similar to every other aspect, be it with veterinarian practice through to in human practice as well. But the question that always comes up is, does it matter? I give the antibiotics, does it really matter if I don't give it at the right time or not? And there's good evidence from a vast number of studies, and this is one of the earliest ones cited, which did show that the timing actually impacts on the risk of surgical site infection. So if you had your antibiotics 3 hours or so post-operation, you actually had a increased risk of surgical site infection. So yes, it does impact on patient outcome. The second question is, giving it for a prolonged period, again, does it matter? And we do know that things such as Clostridium difficile are linked with surgical antimicrobial prophylaxis. We know also, conversely, that patients who are given prolonged surgical prophylaxis following cardiac procedures and other procedures actually have an increased risk of surgical site infections with resistant organisms. So yes, it does actually impact. The other thing we know is the choice of antimicrobials potentially can impact on patient outcomes. So there was a commonly cited issue in the UK where they switched to flucloxacillin and gentamicin, and there were consequences in terms of renal impairment that was seen following this change in prophylaxis. So it does have significant impact on our patients. But the real question is, how do we go about changing behaviour? And the first thing to know about with the surgeons is, or with surgical prophylaxis, is we're not just dealing with the surgeons. There's actually a broad array of consumers and stakeholders involved. I'll let you pick out in this picture who you think is who, but you have the surgeons, you have the anaesthetists, you have the hospital administrators, and increasingly the hospital insurers as well that are playing a part. You have the patient, you have the nurses. So there's a broad range of people who are involved in the decision, and also who you need to target for behaviour change. This is an older paper looking at why physicians don't follow clinical guidelines, and again, it's something that could probably apply to most areas, but I think it's particularly relevant in this area. And it comes down to a number of things: a lack of familiarity with guidelines, a lack of awareness, a lack of agreement, which is a common theme, inertia of previous practice, which means this is just what I've always done and I'll keep on doing it, and a lack of outcome expectancy. So really, these infections are uncommon, complications are uncommon, so you may not actually see the adverse outcomes from your practice. When we look at knowledge barriers, one of the main things is we know that a lot of the practice is just what they've been taught, what they learnt in med school, what they were taught from their senior surgeons when they're operating. And there's really sometimes a bit of a lack of ongoing education or a lack of awareness, particularly about the guidelines. And there is a huge volume of information that the surgeons and anaesthetists need to know, and really trying to educate them about the guidelines is important but challenging. Always when you think about surgeons and anaesthetists, the question about attitudes and attitude behaviour comes up. And again, there are issues with lack of agreement with the guidelines. There's also a lack of outcome expectancy, which I discussed, which is basically where they don't actually see the consequences of their inappropriate practice. There's a lot of problems with lack of or inertia of previous practice, and we know things like gentamicin used for catheter insertion, it was always just what they'd always done, and no one had really challenged them on that. And we know again from some work from Esmita Charani and the group in the UK that they've identified similar issues with this. And also, I think the second quote there, which is talking about people being challenged about their practice, it's not always possible, particularly in the theatre environment. Behaviour, I think, is an important thing. The concept that one size fits all, when you think about the variety of patients that you're seeing, particularly with issues of obesity and overweight patients, really how well do the guidelines fit in with those patients? There's also, we know that there is a limitation to our evidence, and there's significant evidence gaps that exist. So really, are the guidelines completely pertinent for all the patients that they're seeing? The other thing that has coming through is that surgeons and potentially anaesthetists are very, and I think it's again a theme that's come through from other areas, are very anxious about the risk of surgical site infection, and it's actually an overvalued risk for them. And from their perspective, actually, the risk of infection and surgical site infection well and truly outweighs any of sort of the concerns about patient harm and antimicrobial resistance. It's not to say that they don't value those issues of patient harm, etc., but really I think there's a real fear of surgical site infection for surgeons in particular. So really sort of finishing up, and we've observed these issues, but we're really still trying to formulate ways to impact on this behaviour. And I think really an approach, again, generalisable to all aspects of antimicrobial stewardship, is that we're going to need to approach it from a number of different levels, including persuasive, restrictive and structural elements to try to bring about the change. So really, in summary, we know surgical prophylaxis is a high consumption antimicrobial use within hospitals, but also a high rate of inappropriate use. Behaviour change, a bit like we've touched on with everything, is complex. You really need to understand the drivers and behaviours and barriers to behaviour. You have to engage a broad range of stakeholders, and any approach is likely to be multi-pronged. So I'll finish with the acknowledgement slide.